Good evening to everyone and welcome to today's session. Today we shall review the remaining part of autonomic nervous system, which include cholinomimetics and anticholinergics. Then we also have adrenergic agonistic agents which need to be completed, and the various autonomic nervous system receptors, etc., in the ANS pharmacology. ANS pharmacology actually is the biggest chapter in the entire pharmacology. We will also review the very high yielding topic that would be anti-malarial treatment. Any entrance you go, UPSC or USMLE or anywhere in the world, malaria, TB and retroviral therapy, they are the most high yielding topics. Anything about them you need to know. So we welcome our online students, Dr. Shailaja, Brahmaramba, Kavi, Anita, Anuja, Harika, Vikas, and the students of Tirupati, Kurnool, and Vizag and Guntur. So, highly active antiretroviral therapy. Once the HIV virus infects, what is its plan? Basically, it needs to attach to the cell and then it needs to penetrate the cell by pinocytosis and uncoating should happen. After that, the reverse transcriptase will be converting the RNA into DNA. So, a DNA copy needs to be produced. Tenofovir is a drug that prevents the attachment of the HIV to the cell. We have reverse transcriptase inhibitors which belong to nucleoside and non-nucleoside type of reverse transcriptase inhibitors. So if you look at the life of the HIV, the virus basically fuses to the cell membrane and it will be releasing the genome. The viral genome. The viral genome, which is basically RNA, carries with it the reverse transcriptase activity. Then the RNA DNA hybrid will form and DNA will be forming from that, and that become incorporated into the host, that is the human DNA. And then it will be using the host DNA structure and will be producing once more the RNA. Viral RNA, and that will lead to the viral protein formation from the viral RNA, and once more capsid become reconstituted and that become released to infect the other cells. So this is how the cycle happens. So fundamentally we need to have a strategy yes. We need to know the antiretroviral therapy strategy. So, the strategy is, it can be prevention of the entry of the HIV into a CD4 positive cell. Second is to inhibit the reverse transcriptase enzyme either by nucleoside and non-nucleoside analogs. Third is, you can also prevent the viral proteins from getting generated, and the protease inhibitor basically helps in constituting the capsid around the nuclear material. So any of these places you can have these drugs. Now let us talk about, just ask Suresh why. Ask him to also upload the explanations of the mock test into the same Edmodo. He can also do that, the document, so that the students can download the explanatory answers also. Even for the earlier tests, whatever the explanations of the tests are there, ask him to upload. Otherwise students can't write the notes. Okay, we will take care of that. No problem, doctor. Now, nucleoside reverse transcriptase inhibitors. They competitively inhibit the HIV coded RNA dependent DNA polymerase, which is called the reverse transcriptase. By doing that, what will they do? We have seen the transcription, translation. We have discussed in detail in biochemistry, no? So that part. They lead to the termination of the chain, and that lead to the decreased viral DNA synthesis and viral replication. We have seen that after entry, the RNA using the reverse transcriptase forms its own DNA, and that get incorporated into human DNA, and then that will help formation of viral RNA and viral proteins. So this is the entire cycle. So if you prevent viral RNA from getting converted into viral DNA, if the viral DNA doesn't form, viral proteins do not form, because once more the viral RNA doesn't proliferate and viral proteins don't form. If they don't form, virus can't proliferate. So that is the whole idea. So that is the reason, if you use a reverse transcriptase inhibitor, you are preventing the daughters and granddaughters of that infected virus from getting born. Contraception you are doing on the virus. So that prevents infection. But will that clear the already infected cells? No, it can't. Only other cells from getting infected it will prevent. If you give a reverse transcriptase inhibitor, you agree with me? And what is the main problem with this nucleoside reverse transcriptase inhibitors, against which possibly resistance can develop? What is the reason? For the nucleoside reverse transcriptase inhibitor to be effective, it needs to get first phosphorylated. So virus, if it recognizes this weakness of the drug, what it can do? It can develop, it can prevent this kinase which does the phosphorylation of this nucleoside reverse transcriptase inhibitor, so that the drug remain ineffective against the virus. So there is a possibility of resistance. Is there any other drug that you know which also need to be phosphorylated before it shows its antiviral effect? Acyclovir. Acyclovir need to first get phosphorylated. So how will anti-acyclovir resistance will develop? Typically the bacteria will lead to prevention of that phosphorylation. Whatever the kinase is trying to phosphorylate the drug, it will mute that. So in such scenario, what is the drug of choice if there is acyclovir resistance? Favorite MCQ of the examiner. Foscarnet. Because foscarnet is an antiviral drug which don't need any phosphorylation for it to be active. That's the point of interest. Okay. So nucleoside reverse transcriptase inhibitors need to undergo phosphorylation before they become effective. Is the point. That's right. Is the point that you need to basically remember. Zedodine. In a third world country, are we third world, fourth world, 10th world, underworld? Which country India is? India is the third world country with the richest and multi-billionaires in this country. We are a admixture of both poverty and stinking riches. Zedodine is a wonderful drug. So zedodine is also called azidothiamidine. It is a analog of the thymidine. So whenever the RNA says to the tRNA, mRNA calls and says, thymidine ko bulao, call thymidine for it to be incorporated into the DNA, into the RNA synthesis. When thymidine should be incorporated, zedodine will go and sit instead of thymidine, not due to translation, during transcription. We have seen, no, from the nuclear DNA, mRNA genes rRNA genes, tRNA genes will lead to RNA formation. So DNA dictates what should be composition of the nucleotides in the RNA. So during the formation of the RNA, when thymidine need to be incorporated, that time zedodine will go and sit there and destroy the chance of forming the RNA. Okay, so that is how it basically acts like a reverse transcriptase inhibitor, is what need to be remembered. So zedodine is a pyrimidine analog of thymidine. It has adverse effects. What are the adverse effects? Headache, diarrhea, fever. Forget about them. You don't remember. Everything has got those same side effects. What is the dose limiting toxicity of the zedodine? Is the favorite MCQ of the examiner. Bone marrow depression. But it's a huge confusion in an antiretroviral therapy patient if he develops anemia. Anemia can be due to malnutrition. Anemia can be due to internal bleeding. Anemia can be due to some other drugs. For example, for pneumocystis carinii pneumonia, if you are using pyrimethamine, then or for the CNS infections, if you are using pyrimethamine can lead to megaloblastic anemia. There are 1,000 reasons why anemia can develop in a HIV positive patient. One of the causes you should think is the zedodine, which is used in the antiretroviral therapy, can lead to bone marrow depression, which can lead to development of anemia, is what you have to basically remember. So granulocytopenia and anemia. If I give zedodine, patient will ask you a innocent question. Sir, will this reduce the rate of progression of HIV? Yes, sir. Zedodine reduces the rate of progression. Can you give it to the pregnant women, sir? Yes, sir. You can give it safely to the pregnant women. You can give during the pregnancy in the second trimester, at the time of the labor, and after that to the newborn. And if you use the zedodine, the vertical transmission of the HIV is reduced by about 25%, is what you have to remember. Another high yield fact, which is commonly asked in exam. So as a busy resident, you are injecting and by chance you have hit the HIV needle. What do you want to do? I took antiretroviral therapy twice. 2 times I was hit when doing MD general medicine. So nothing will happen. First thing, you should not panic and don't inform that good news to your classmates. So they will be saying, please get your HIV status immediately checked. So without any panic, you should take a post-exposure prophylaxis. Only painful part is 1 month you need to abstain, and after that you need to get evaluated. And you need to hold your confidence and conscience without becoming too anxious. That's the whole logic of that. So post-exposure prophylaxis, we can very much use the zedodine. How about diadenosine, doctor? Diadenosine is a purine analog. These are all basically nucleoside reverse transcriptase inhibitors, means they themselves are like nucleoside. A police can only be able to catch a thief. If a thief can become a police officer, he can catch the thief much better. So that is the rule of using reverse transcriptase inhibitors, are all by themselves nucleosides, which are required for the reverse transcriptase to basically create DNA from the RNA. And it gets confused whether I am incorporating the real nucleoside or pseudo nucleoside. It gets confused and wrongly inserts the azidothiamidine instead of thymidine, that is zedodine instead of thymidine. So that's how it gets blocked. So it is a purine analog. But to take diadenosine, what is common between taking diadenosine and thyroxine tablets? Both should be taken in empty stomach. So that's a problem. And what are the dose limiting toxicities of diadenosine? One of the favorite MCQs of the examiner. sensory peripheral neuropathy, pancreatitis, optic neuritis. Many times in exam this high yield fact, there is a very high yield fact, didenosine side effects. You should remember it like a parrot. So which antiretroviral drugs do not cause peripheral neuropathy, doctor? Lamivudine and zedodine. Let me know, is the voice clear without any echo? Please punch. Are you having a clear voice into the chat window? Is it loud and clear? Yes. Lamivudine and zedodine. And what are the antiretrovirals which cause peripheral neuropathy? Didenosine, alcitabin, stamidine are the ones which typically lead to development of peripheral neuropathy. So what is stamidine? Is the next important question. It is also a thymidine nucleoside analog. And stamidine is very similar in its side effects to the didenosine. Only thing is, acid lability is a issue, except for the acid lability, it is labile to acid. Everything else, pharmacokinetics, therapeutic uses, adverse effects, everything of this stamidine and didenosine are similar. Then what is alcitabin? Basically, it will terminate the elongation of the viral DNA. You have seen, no? How is basically DNA formed? When DNA is forming, one after the other nucleoside keep on adding to that RNA primer, right? So that DNA chain elongation get terminated if you give alcitabin. It is also a drug that need to be remembered, peripheral neuropathy. In fact, it should be first remembered when we talk peripheral neuropathy. Why? 1/3 of the patients who take alcitabin will end up in paresthesias. Peripheral neuropathy becomes a side effect of alcitabin. Then few comments on lamivudine, emtricitabin and abacavir in the same class. Lamivudine is also another analog to cytosine. So you must know which drug is analog to which nucleotide. Till now what did we finish? Azithromycin is zedodine, thymidine analog, etc. etc. So cytosine analog is lamivudine. One of the main side effect is headache and GI upset if you use the lamivudine. Headache, insomnia, fatigue, GI discomfort. These are all the side effects if you are using the lamivudine. But what is the comfort of lamivudine, doctor? Lamivudine, zedodine. No peripheral neuropathy. This is such a high yield fact once more. Examiner will keenly ask you in the tomorrow's exam, do you know which drugs antiretroviral do not cause peripheral neuropathy? Only two. Lamivudine and zedodine is what you have to once more remember, doctor. Let me tell you, antiretroviral therapy topic is not a cake to swallow that easily. Mainly because of this too many memorable lists that you need to, but I am trying to precipitate what is most commonly asked memorable things. There are many more things mentioned in the book, textbook, but all are not, our human thing is beyond remembering everything. Stamidine. For stamidine, if I ask you, what is the major dose limiting side effect? Peripheral sensory neuropathy. For didenosine, what is the major toxicity which makes it dose limiting? It is the pancreatitis in the case of the didenosine. Then what is emtricitabin? It is nothing but a fluorinated analog of the lamivudine. Always, for any disease or condition, what is the preference of patient? Give me only one time taking tablets, sir. I am happy. If you can give me once in a year taking tablet, I am much more happy, right? So, long half-life of this fluorinated analog of the lamivudine called emtricitabin will enable once daily dosing is a great advantage. So, what is abacavir? It is an analog of the guanosine, basically, abacavir. But about abacavir, one very commonly asked high yield fact is fatal hypersensitivity reaction. Hypersensitivity occur and person dies. Abacavir is what you have to fundamentally remember. Then tenofovir. It is an analog of adenosine. So some analogs are for cytosine, guanosine, stamidine. Similarly for adenosine. What is the main advantage of this tenofovir? We also use tenofovir even in the people who have other viral infections like hepatitis B also. Very commonly used by the gastroenterologist. Tomorrow some of you are going to be DM gastroenterology. No time. Today you are waiting for an opportunity called entrance exam. Nowadays entrance exam also has become an opportunity. अगर मिल गए तो हम थोड़ा लिख के कुछ ना कुछ join हो जाएंगे. At least some or the other exam let it happen kind of a state we have reached. So tomorrow you will finish MD, then you will become doctorate in medicine and you will be one of the leading gastroenterologists practicing in Twin Cities. So tenofovir, you will not forget for hepatitis B. So it is more convenient than the older antiretrovirals because of once more that once daily dosing. But the problem with the tenofovir is once more GI side effects like flatulence. Patient should be adjusting with them. Then what are non-nucleoside? They don't resemble in any way to the adenine, guanine, thymine, cytosine, but they inhibit the reverse transcriptase. The main difference between the nrtis and nrtis is nrtis require phosphorylation for them to be effective. Obviously no. If the thymidines imposter, who is imposter to thymidine? Azidotymidine, which is zedodine. When will reverse transcriptase get confused? Thymidine triphosphate versus azidothymidines triphosphate. Between the two it get confused and unfortunately it will, for us fortunately, it will take azidothymidine triphosphate and its production stops. So phosphorylation is a requirement for nrtis but not for nnrtis is what need to be remembered. So what are the group of drugs you want to remember? Nevirapine is a very important drug. It was long back when first time I was hit with the antiretroviral, with the HIV needle. So that time there was a ward discussion. Which antiretroviral should be started on Dr. Murali Bharadwaj. So there were a lot of WHO studies, etc. Same time one Steven Johnson patient was admitted in the ward. After looking Steven Johnson, I have decided, I was given two options. Do you like to accept the risk of Steven Johnson's if you take the nevirapine? Or other option is you can take efavirenz. But there will be suicidal depression. I said it is only for the guys who can possibly get depressed. I am the guy, even efavirenz cannot be able to depress. I think that is preferable than this. Suicidal depression with efavirenz you can never forget. I can never forget. So some drugs when you experience you will know. So nevirapine is typically used in combination regimes. So it will reduce the vertical transmission. Even in fact earlier zedodine was given, no? Later on, whenever nevirapine was used, it was used as a part of the combination chemotherapies. It was never given as a monotherapy. But one of the recent recommendation of the Obstetric Society is, you can use it in pregnant women just like zedodine is used as a monotherapy. So nevirapine monotherapy is indicated as antenatal prophylaxis for a retroviral pregnancy is what need to be remembered. Stephen Johnson will be saying, shall I come to you? Toxic epidermal necrolysis and hepatotoxicity. So these are the important issues with the nevirapine. Then another important thing is the drug interactions of the nevirapine, doctor, you can never forget. Because this is one common issue about nevirapine. Till now for the nrtis, drug interactions was not very serious matter. From nevirapine we start talking about protease inhibitors and nrtis, we need to talk a lot about drug interactions. Nevirapine and ketoconazole concurrently if you use, it will increase the plasma levels of nevirapine, same time decreasing the levels of the ketoconazole, because nevirapine induces the CYP3A enzyme is a very high yield fact which you should not forget. Then rifampicin, you know, is a inducer of microsomal enzymes. If you give nevirapine with rifampicin, then the levels of the drug become reduced because it is hypermetabolized. Then dilavudine and efavirenz are the other NNRTIs. Regarding dilavudine, what will you remember, doctor? You can't remember. Rash and GI upset. It is common to many. It is also metabolized by the CYP3A system. So better you remember only nevirapine and think that anything about dilavudine is equal to nevirapine. More easy to remember. Efavirenz, you can't. One advantage of efavirenz is once daily dosing. Only one time you can feel sad, array, I am taking a antiretroviral drug. So it is dosed once daily. CYP3A metabolizes it, but giddiness, insomnia, confusion, amnesia, nightmares, and suicidal depression and CNS effects. To overcome the depression, almost 15 night duties we have done that month. So that 30 days almost staying in the hospital. Even if you depress, if you want to jump, you can jump from the kidki of hospital only. And even if you jump, you will end up in hospital only. So that's a advantage. Sometimes, one more of my very good friend, in the same week, while doing a hepatitis C virus patient, he was doing a hemodialysis and the entire blood splattered into the eyes. So we both sat and started Bhagavad Gita. So, what is that very famous dialogue in Gitanjali movie? You will die, I will die, maybe after a few years you will die. So, better if we die, we are dying for a good cause. So, doctor, never be panicked. At least after that, I still remember 15 to 20 of my students many times gave a call that we had a retroviral needle prick. None of them are with God's grace, not really infected. So doctor, 50% of the patients, once over a period of time, once they are using, they will overcome that. But that initial phase to adjust is difficult. So once the DNA copy of the viral RNA forms, it integrates into the host genome and it transcribes the viral DNA, from which there is a translation of the viral RNA, and from that the viral code proteins will form and they typically become assembled. And if you use a protease inhibitor, you are preventing that assembly of that viral proteins which are formed for the virus granddaughter to be born. You are preventing that by giving a protease inhibitor. Sakinavir, ritonavir, indanavir, nelfinavir, but not abacavir. One of the favorite MCQs of the examiner. Don't think all virs are protease inhibitors. The only vir which is NRTI is a backwear is what need to be remembered. Now, HIV-1 protease inhibitors, let us talk about it. Is the voice fine or is it broken? Just check. If the voice is loud and clear for the audience, or is the problem with Sundaram? Sundaram had the voice slightly broken. Please punch, is the voice clear, doc? HIV-1 protease inhibitors, they inhibit the GAG-pol polyprotein cleavage, which is a very important step for ultimately virus to be packed and matured virion to be produced. So that is the reason what will happen if protease inhibitor is given. Virus enters the cell, uses the reverse transcriptase, produces the viral DNA, incorporates into host DNA, produces the viral mRNA, viral proteins, but those proteins can't be integrated into the daughter virion is the point of interest. So how will you use the protease inhibitors, doctor? You combine them with nucleoside analogs, and if you combine the protease inhibitors and NRTIs, then you can in fact reverse the clinical progression of the acquired immunodeficiency is the point of interest. Now, what is the most important high yield fact about PIs, protease inhibitors? Frequently associated side effect of the protease inhibitors is the development of lipodystrophy. Patient's wife will come to you and tell, oh, what a nice doctor you are. My husband, who was earlier emaciated, is looking very chubby, he put up the weight, he's looking handsome. Only thing is you need to caution her. All that weight he has put up and all that chubby look is not a healthy state. I mean, it's not equal to that he's absolutely healthy. So that's very important. Lipodystrophy. So let us see. Protease inhibitors will lead to this kind of a buffalo hump-like appearance. But the distribution is, why then called dystrophy? It is abnormally distributed. If you look in the face, the facial fat is not incorporated. It only incorporates in nape of neck and abdominal fat. So that is a lipodystrophy. Protease inhibitors as the side effect, have a side effect you are not going to forget. Protease inhibitors also have interactions leading to the inhibition of, because of the inhibition of CYP3A4 that they lead to. Now with protease inhibitors, what is the main issue? Resistance to the protease inhibitors is one of the main issue. What is the reason for it, doctor? Patients, number of tablets you need to take are this many every day. They are not like a one tablet one day like efavirenz scenario. It's not like that with protease inhibitors. That's the reason patient become non-compliant. He'll go to drug holiday. And whenever, if you use only protease inhibitors without anything else, generally you should combine them with NRTIs, monotherapy. Or if you give in a subtherapeutic level, then that leads to development of protease inhibitor resistance. Now, 1-2 comments about each of these protease inhibitors. Sakinavir. Typically, any drug which increases and induces the, like rifampicin, the liver microsomal system will lead to the reduction of the bioavailability of the sakinavir. And sakinavir is generally very well tolerated, but the main issue with sakinavir is bioavailability. Any alteration in the P450 immediately will affect the sakinavir, just like warfarin. So that is the main problem. And there is an extensive first pass metabolism is the buzzword. You need to remember when we talk about sakinavir. So that is the reason we combine with ritonavir. The saquinavir is combined with ritonavir, which is another protease inhibitor, is what need to be remembered. So what is the main side effect? Side effect is not important because it's difficult to remember. GI disturbance and rash. Then ritonavir. Always when you give ritonavir, you must closely monitor the ritonavir because it inhibits the cytochrome P450. So why do you combine saquinavir with ritonavir? Since it inhibits the P450, saquinavir is now more metabolized, so bioavailability will improve. Hence we combine saquinavir with ritonavir is what need to be remembered. And what is the main side effect profile of ritonavir? Perioral paresthesia and taste disturbances. These are the commonly asked questions about the ritonavir's side effects. Okay, doc? Then we also combine lopinavir and ritonavir, just like saquinavir and ritonavir are both combined together. These combinations you should not forget. Then indinavir, what will you remember about it? Just like ritonavir, it will also affect the microsomal system in the liver, and it is very well tolerated drug, indinavir. But one very important high yield fact about indinavir, nephrolithiasis, is what you need to remember. And what is the reason for that? The very drug, which is indinavir, it precipitates in the renal collecting system. The drug itself leads to formation of stone. It does not lead to uric acid or calcium or oxalate, blah blah blah. Drug itself. So how can you prevent that? By basically giving good hydration to the patient. Then another common side effect with indinavir is liver toxicity, leading to indirect hyperbilirubinemia is one of the important issues. Then nelfinavir, emaprinavir and emaprinavir, the other important protease inhibitors, one to comments about them. They all have similar problems, advantages and disadvantages like indinavir. Emiprenavir need to be remembered because the severe rashes, but just like you can combine lopinavir, saquinavir with the ritonavir, you can combine even the emiprenavir also with ritonavir. That's the reason you need to remember. Then they have slightly modified this emiprenavir and made fosemiprenavir. It is the one, the advantage is once daily dosing is a great advantage. Then atazanavir is the next protease inhibitor. That hepatotoxicity you have seen with indirect hyperbilirubinemia, you have seen with indinavir, no? That is also the problem with azetonavir. And drug-drug interactions are also need to be remembered about azetonavir. Then tiprenavir. Why do you want to remember? Right? So all these drugs look like Betal Puja. Huh? But first time you read, second time they become easy, third time they become cheap, fourth time you will start as such you have treated 1000 patients of retroviral disease. That confident you become. But that's the reason pharmacology like subject, where you will keep accumulating like drug toxicity. List to remember, one after another list, 4 causes, 5 causes, 6 drugs, 7 drugs, 8 drugs, leading to this, leading to that. Better keep the list short. Check whether it was previously asked in the exam or not. Is the examiner expecting or not? So that limit the number of facts to be remembered is more easier to remember the facts. And don't be afraid. In spite of reading all these things about the antiretroviral drugs, something in the corner of the book examiner can ask in exam. He won't ask, sir. Because totally there will be some 50 to 60 facts Very high yield facts about antiretrovirals, which you need to know. So tipranavir, what you need to remember and what is commonly asked in the exam is, which is that antiretroviral drug whose bioavailability will increase if you take it with a high fat diet? You need to remember tipranavir. Like other protease inhibitors, it also undergoes a very high first pass metabolism. It can be co-administered with ritonavir. And one of the black box warnings about tipranavir is the hepatic dysfunction. Till now, how many drugs? Indanavir, hepatic dysfunction. Tipranavir, hepatic dysfunction. What else? Etazanavir, also known for hepatic dysfunction, indirect hyperbilirubinemia, blah blah blah. You need to remember. Now, doctor, HIV entry inhibitors. Entry inhibitors are like the airport mein visa officers, passport officer. He will check passport hai kya nahi. So we have what are called as fusion inhibitors, which prevents first of all virus to come and blend with the host cell membrane. Enfuvirtide, if you take the past 5 years of All India AIMS PGI exam, repeatedly asked question is mechanism of action of enfuvirtide. You need very high yield fact, which you need to know. Enfuvirtide blocks the entry of the virus into the cell by binding with which viral glycoprotein, doctor? GP41 is a glycoprotein to which it will be binding. Enfuvirtide is a good drug, but it can only be given subcutaneously. Chuzion is its commercial name generally. It is active only when injected subcutaneously. And this part of enfuvirtide makes it a costly one. It is not just taking one pill, taking water, and once more having a free sexual life. That is not the life of the patient. Taking injection, half the motivation of his limbic system is gone down by that. On the top of it, the cost of buying an injection, getting it injected, and he is vulnerable for a lot of infections. There is a whole problem in management of giving enfuvirtide. So fundamentally, doctor, injection site reactions are very common. Enfuvirtide is given as a part of the combination therapy. So finally, let us talk about the heart. Highly active antiretroviral therapy, where you will basically be combining 3 to 4 agents. The main idea is to prevent the development of resistance. So what are the options which are available for you? Preferred options. First, let us talk. nrtis is a wonderful choice. Efavirenz is a preferable one among the NNRTI. Once daily dosing. Little insomnia, suicidal tendency, patient will overcome after a period of time. You can remember it very easily. Then other option available is protease inhibitors. Between the two, one you need to choose. Combine it with one NRTI. That's the idea. Either you can choose an NRTI like efavirenz or a protease inhibitor you can choose. Which protease inhibitor combinations are famous? Etazanavir plus ritonavir, fosamprenavir plus ritonavir, lopinavir or ritonavir alone or combination. So these are the options which are available for you. But ritonavir is one of the most preferred protease inhibitor to initiate if you choose protease inhibitor instead of efavirenz. Clear? That you will combine with a NRTI. What are the options available? Depends on your purse and pocket. How many millions your dad left, or your ex-girlfriend or a boyfriend who had retroviral who infected you has left you as a compensation, or your employer who led to the injection has left you. Purse matters. Zedodine plus lamivudine is a combination very famous, or tenofovir plus emtricitabin, that is a lamivudine's fluorinated analog, which will enable once daily dosing, we said no. That is another important combination. Tenofovir plus emtricitabin is another choice. Why will you remember tenofovir? I told you, you are the famous gastroenterologists who are going to treat hepatitis B also. Tenofovir you are not going to forget. Plus emtricitabin or zedodine plus lamivudine is a combination. Alternatives क्या होगा? Instead of efavirenz, if suicide is a big issue, you can give nevirapine. That is a nrtis you can give. Then remaining things, but don't remember this table because alternatives are always, all other drugs are alternatives. What is asked in exam is, at least at undergraduate level, if you know what is the first preferred options available. So which regimes are not recommended, don't combine them. The jugalbandi mein besurdas ho jayega. So which jugalbandi is not permitted. Stamidine plus zedodine, don't combine, because both of them are thymidine analogs. They both themselves will compete for who will go and attach with reverse transcriptase. Stamidine plus diadenosine, don't give it, because it will increase the toxicity like lactic acidosis and pancreatitis. It is common to both of them. That will definitely occur, right? Then emtricitabin plus lamivudine, don't combine, because the resistance profile is same to both of them. This is one of the favorite MCQ of the examiner. Which drug combinations will not do well? Just like in medical college we used to say no. Sagittarius marrying a Gemini, Scorpion marrying a Pisces. So some combinations are good, some are bad. Ultimately when you meet after 10 years after leaving medical college, you will discover any combination is good and any combination is bad. So some combinations are not good. Star signs don't match. Then some components are not recommended as a part of the regime, which you need to be very, very sure about. For example, sakinavir, darunavir or tipranavir, whenever you give them, you need to combine them with ritonavir. Otherwise, alone if you give, any alteration in the hepatic microsomal system will affect them and their bioavailability become obscure. Efavirenz, don't give it in pregnancy, sir. Zedodine is okay, nevirapine is okay, not efavirenz is not okay. Emprinavir's oral solution is not good because of the propylene glycol content which is used to prepare the oral solution. Emprinavir and fosamprinavir don't combine because both of them are mixing scotch and beer. Both of them are the same forms. Etazanavir and indinavir, they both are liver toxic highly. Don't combine. Hyperbilirubinemia will worsen. So whenever you have a naive patient, not the one who became resistant, what is the best choice which is available for you? Triple nrtis regime. When will you use that? When protease inhibitor or nrtis based regimes if you can't use, then you can use a triple nrtis regime is the one which you can use. But what is preferable generally? One nrtis combined with either efavirenz and nevirapine are called as either efavirenz or nevirapine. You choose one. If you can't choose between either of them, then you choose protease inhibitor. So that you combine with one nrtis. Not one nrtis, two nrtis. Got the point, no? Two nrtis with either a NNRTI like efavirenz or nevirapine, or with one of the protease inhibitors. That is a general regime that need to be remembered. Then what is maraviroc? One of the favorite questions of the examiner, very commonly asked in the exam. It is CCR5 inhibitor. They found that some guys, even if they get infected with HIV, they were not progressing into retroviral disease. What is the reason? They have a genetic advantage that their CCR5 receptors in few people, not all people. Don't tell this to your patients. So they will be asking, can you check whether my CCR5 also is a resistant one, so that I can continue the same great clandestine nocturnal creeping life. I can adapt. Patient may ask you. So CCR5 inhibitors. So they found that those who have this mutation of their CCR5, even if they go and fall into a pond of a HIV blood pool, nothing will happen to them. Right? I still remember one more nightmare while doing MD was one retroviral patient who himself was on antiretroviral therapy has gone into psychotic state, broken a glass, cut himself and start running. I'll infect all of you. So that's the reason, doctor. But the patient was in a psychotic state. So first we need to be bold for being a good doctor or a bad doctor, whatever it is. So maraviroc is the one which you need to remember, CCR5 receptor blocker. So what will it be doing? It will be preventing the interaction of a HIV1 GP120 and a human CCR5. These two are prevented from binding with each other so that the entry become affected. So that is the purpose of maraviroc, and you need to remember which GP? GP120 is the one which you need to basically remember. So summarize, doctor, before we say goodbye to this topic. NRTI, zedodine, what will you remember? Bone marrow depression, nausea, nail discoloration also. Abacavir, you will remember fever, rash, blah blah. Lamivudine, generally very well tolerated. Emtricitabin, hyperpigmentation of the palms and soles can occur. Then stamidine, peripheral neuropathy, pancreatitis and hypertriglyceridemia. Diadenosine, pancreatitis, peripheral neuropathy. Tenofovir, flatulence and nephrotoxicity sometimes. This is how the lipodystrophy can typically occur in the people with a facial wasting. In the case of protease inhibitors, due to the lipodystrophy is what you need to remember. So doctor, that brings us to the end of this